Okay, thank you. Hi, everyone. Thanks so much for joining us this afternoon. This is Valley View University, the Women's Health Series. I really appreciate you all joining. We're going to start the talk pretty quickly, but just a few housekeeping things to start with. You can submit questions at the bottom of your screen, and we'll get to those at the end of the lecture. Please make sure you're not putting any personal health information in there because these can be viewed by other people. Okay, let me start sharing. Maybe. Yeah. Okay, great. Thank you. All right, so today we're going to talk about women's health and weight loss clinic here at Valley View. I'm an OBGYN at Women's Health. I've been here for about 12 years, and we started a weight loss clinic about 2.5 years ago, and something that I'm really passionate about and was really excited to give this talk. Uh, Maybe I can get this to work. Oh, there we go. Okay, excuse me. Just a disclaimer here that this does not replace an actual doctor's visit. My objectives of my talk today are to help make sure you all recognize the burden of obesity and how that impacts our health, appreciate the context for weight loss need, how important that is to our communities and to ourselves, and then describe what treatment options are out there, and then just a little information about the weight loss clinic at Women's Health. We're not the only weight loss clinic at Valley View. There's several, we can help refer people to those clinics if needed. So this is a little cartoon that I like and is used a lot to describe obesity. So basically, we spend a lot of time picking up, well, in this case, the mess, but basically the complications that are associated with obesity without actually preventing obesity or being proactive to helping a lot of those health issues. And so I think this describes where we've been for a while now. So the next couple slides are just going to talk about the burden of obesity within the US. This is 2022 data. And the specifics are not super important, but just look at the colors. As there's more obesity, the colors get more intense. I always like to say that in Colorado, we like to talk about us being the thin state. But even for us, 25 to 30% of our population of adults is dealing with obesity. Actually, maybe just let me step back a minute in case people are not familiar with that term obesity. That comes from body mass index or BMI. That takes your height and your weight and puts it on a scale. And if anybody wants to calculate the BMI, it's really easy. Just put it into Google. But anything 25 to, well, 19 to 25 is considered normal weight. And then 25 to 30 is overweight, and 30 to 30 plus is obesity. So anyway, so this is all adults in the US in 2022. Especially in our community where we have a lot higher Hispanic rates, we can see that the Hispanic population has higher rates of obesity for multiple reasons that we can talk about, but really high concern there. And then even higher are our non-Hispanic Black populations to the point where reaching levels almost up to 50%. The next two slides, I think, are what keep us up at night, make us really nervous. The first is this is a graph of children, and those are the overweight and the obese. It's the higher rate, especially in the South and Midwest. But basically, 1 in 3 children are struggling with their weight. And we know that the trajectory of those kiddos' lives are significantly impacted by their weight issues earlier in life. And we're seeing disease processes that we never saw in kids before, like type 2 diabetes, high cholesterol. And so really impactful and concerning for the next generation. And then this one, I think really scares us all. And this is an estimate of by 2030 that nearly half of Americans will have obesity. And you can see, again, South Midwest, really high burden for disease. But if you think about all the things we're going to talk about, and 50% of us could be struggling with that, it can have huge impacts on our nation. This is a graph of obesity rates worldwide. We are not the only country that's dealing with this. As you can see, there's lots of different countries that also have higher rates of obesity. So I love this little cartoon, and I know it's a little old. Bird flu is not a huge thing anymore, but I think it's still true that when you look at the global threat to all populations, you put all the different other problems that you hear about. We spend so much time on media and screen time and money and all these things on all these different problems, whereas obesity is probably the most impactful problem that we really have. I just wanted to show this really quickly. I know it's a little bit busy slide, but let me explain it. This is specific for women, especially that obesity rates, although impacts all incomes and all ethnicities. So you'll see here, this is total non-Hispanic whites, non-Hispanic Blacks, and Mexican Americans, but that as your income goes down, your rates of obesity go up. And so income and obesity are pretty tied together. I don't think that's hard for us to imagine. If any of us have gone to the grocery store lately and bought fresh fruits, vegetables, eggs, the food has gotten very, very expensive. Whereas canned goods, things that we really shouldn't be eating, are not expensive. And so just wanted to point that out. So I tried to put a cost of obesity, and I think this is really hard to name, but a couple of studies had looked at different things that I wanted to point out. So adults with obesity compared to normal weight spend about $2,500 per year increased on their health care, which is actually 100% increase from a normal weight person. And in general, the estimation is about 14 years of decreased life expectancy with obesity, which is actually similar to lifelong smoking, which we all know is not very good for our health. Also, there's studies looking at not only the decreased life expectancy, but the life quality at the end of life is significantly impacted. In terms of just effect on the workplace, when we're already struggling with workplace issues as our population is aging, patients with obesity or people with obesity, they have a lot higher cost with absenteeism, short-term disability, long-term disability, workers' comp are all a little bit higher, and those estimates are per year. Again, thinking that 50% of our population might fall into this. And the reason for this is some of the health issues that come with obesity, patients or employees missing work because of that, treatments, et cetera. So why do we care? So the big deal is that obesity significantly impacts many areas of our health. Some that you're probably familiar with, for example, type 2 diabetes, cardiovascular disease like hypertension, heart failure, MIs. Those we know often are attributed to obesity, but there's lots of other health issues that are also as well. For example, mental health disease, depression, anxiety, panic disorders are all higher risk with obesity. There's fatty liver disease, which people might have heard of, that's causing a lot of issues with liver failure and problems. Even the pulmonary setting, sleep apnea, asthma, COPD. Urinary genitals, so urinary incontinence for women is a huge issue. And actually, Dr. Lowe is going to talk about that next week. But we know that is also can be correlated with obesity. Then looking a little bit more in my area, the reproductive health, not only does obesity increase the risk of polycystic ovarian syndrome, but it can decrease your chances of getting pregnant, increase your chances of a miscarriage, and then significantly complicate your pregnancy. Not only are there higher rates of gestational diabetes, preeclampsia, much higher rates of C-section, actually, which is a huge issue within our field. And now there's more studies going on that if your mom, the maternal obesity and the biochemical things that happen in their body can impact the fetus. And in fact, if your mom was obese, your higher rates of obesity irrespective of genetics. So impact on the fetus as well. Another one that I wanted to kind of just point out that a lot of people forget about is how much obesity impacts cancer rates. So these are a list of all the different cancers throughout the body that are impacted or higher with obesity. In fact, specific for women's health, breast cancer, about 20 to 60% increased risk of breast cancer for obese women. Endometrial is another issue that I deal a lot with. It's the most common female genital tract cancer. And that's actually 7 times higher in women that have obesity. So not just our common things that we think of, cardiovascular disease, it can impact so many different parts of our health, including our cancer risk. So the big question is, why as a society are we getting more obese? And the answer is it is very, very, very complicated. I think this is part of the problem is that for so long, we've thought this was somehow a personal failure, that all people needed to do was eat less and exercise more, and that's why they were getting obese. And what we've found is that's actually not the case, that obesity is very complicated. So this is a very busy slide, which I'm going to break down and talk to you guys about in a lot more detail. But just to kind of give you the overview, I like this a lot because it breaks down obesity into inside the person and outside the person. And then it breaks it down into what increases our intake of calories, what decreases our expenditure of calories, and then what is either both or unknown. I'm going to talk a lot about these, and then especially when it relates to how it relates to women. So first, just going outside the person, the things that the person really doesn't have a lot of control over. And the first is environmental or chemical toxins. We are learning new stuff about how some of the chemicals we're exposed to are causing earlier puberty in girls. I think there's a lot of things we're exposed to that we don't even understand how they're impacting us. There's an increased availability of energy-dense foods, but nutrition-poor foods. The best example I have of this is soda. So lots of calories in them, but not any nutrition. And those foods tend to be easily accessible to us. They're quick things we can grab, but not very good for us. I think there's a huge lack of nutritional education. A lot of eating out or eating away from home, lack of family meals, always on the go. Skipping meals is actually a risk for obesity, a lot. I think larger portions, and I have a slide just about this, I think are one of our biggest issues that we have. I also think, especially within certain populations, eating as a recreation, like the only time we can get together with friends or family, it involves food. And eating, going out with friends, we always go out to dinner, right? When we meet as our family for holidays, it always involves a ton of food. So that's a big issue. I think there's a lot of, especially for kids, pervasive food advertising, a lot of advertising spent making us think that certain foods are healthy for us. I always kind of joke with my patients, these companies have a lot of money for advertising. The person who doesn't have a lot of advertising money is the pea farmer. And so that's, I think, very persuasive and not accurate. If you go into this next category, maternal stress is a big one, maternal obesity that we talked about. Having kids in general is a big risk for women having obesity for reasons we can't explain necessarily. Birth by C-section increases risk of obesity. Women working outside the house is a big one. So non-paternal childcare. This overnutrition during pregnancy is important, especially for women who have a lot higher rates of depression, anxiety. The most common medications, which are very helpful for those, can cause some weight gain. So weight gain inducing medications. Sleep is something that's very important to risk of obesity, as well as losing weight if we're not getting good sleep. In fact, the hormones that make us feel full are released during REM sleep, which is some of our deeper sleep levels. And so if we're not getting good sleep, we're not getting as much of those levels. There's definitely some issue about family conflict, living in areas that are crime prone. For example, if it's not safe for you to send your kids outside to play, that's an issue. Stress is a huge component of obesity, and now we're learning the biochemical ways that that's impacting why high stress leads to increases in our weight. Something else we're going to talk about a little bit later is yo-yo dieting, or this weight cycling actually increases our risk of obesity when we diet, lose weight, and then we gain the weight back. Increased sedentary time, especially screen time, a huge issue for our kids. And then decreasing opportunities for non-exercise based physical activity. So labor saving devices, for example, driving to work, driving kids to school versus making them walk. My example is my automatic vacuum cleaner, which is probably going right now instead of me vacuuming. All those things over time can really impact our weight. Going to inside the person, something that we talk a lot about in my weight loss clinic is disordered eating, emotional coping eating. Women especially have a lot of risk of emotional eating. Going down, age-related changes. Menopause is the most obvious one I spend a lot of time dealing with. And in fact, Dr. Cruz is going to talk about menopause at one of the later women's health series. But we know that women's metabolism, that means the amount of energy that we expend just living, drops at menopause. We don't exactly know why that happens, but we know it does. And so that causes some weight gain. Chronic inflammation is another big area of studying how chronic inflammation increases rates of obesity. There's other disease processes, the most common being thyroid, that can impact weight. There are mood disturbances just in and of themselves that can increase rates of obesity, trauma history. Going down to decreased expenditure, there's a lot of research going into the gut microbiome and how the foods we eat impact that and how that can be contributing to obesity as well. So as you can see, there's lots of things both inside and outside the person that contribute to the reasons why, as a population, we are getting more obese. This is my fun slide that I threw in just to show how portion sizes have changed. I think what we think of as an appropriate portion is completely inaccurate, and that's changed significantly over the years. If you look at like this first one here, this is a burger and fries and a soda in the 1960s, and this is even 10 years ago, and the percentage increase for the soda is 500%. The hamburger is almost the same. Fries, 250% increase, and so it's not hard to understand how when we see this, we think this is a portion of food, and instead it's actually 5 portions of food, and that this was much more accurate. So some of obesity is not necessarily always changing everything that we eat, but also just changing the amounts we eat. I thought this was kind of entertaining, just what bottled beer is and how that's changed over time. Chocolate bars, kind of the same thing. And so for example, if you go to a restaurant, the amount of food that they give you is more than anyone should be eating at one meal. And in fact, I always tell my patients with this visual, like this is your stomach. And if you're eating more food than fits in your stomach, you're overeating. So if you ever eat on a regular plate, you're 100% overeating. And so just keeping that as your visual and re-educating ourselves on what is an appropriate portion. And if we can just decrease our portions by 20%, decrease our calories by 20%, that can have a huge impact over time on our weight. So most of what I've talked about is kind of negative, but this is one of the positive slides, how much weight loss is necessary to improve health. And this is just one study that looked at it, but basically the good news is that we can improve our health significantly if we can lose weight. So just 2.5% body weight loss, so that's can improve glycemic control for diabetes, can help overall physical function, 5 to 10% can improve our cholesterol, can help our knee pain associated with osteoarthritis, improve urinary incontinence, decrease risk of depression, help our blood pressure, improve quality of life. Greater than 10%, which is a huge, what most of us in medicine think is like really the goal for people is to get them over 10%. It can improve sleep apnea, decrease cardiovascular events like MIs or heart attacks, improve fatty liver disease. That's what NASH stands for in this slide. And if we can get over 16%, we can actually significantly reduce our risk of mortality. In fact, if you look at bariatric surgery alone decreases the risk of death and cancer by 35%. So we can improve our health outcomes if we can help people lose weight. So how do we help people lose weight? And so for years and years and years, myself included, when we talk to patients, we talked about diet and exercise or lifestyle changes. And I think we've made a big mistake. We've been, as an example of us being retroactive instead of proactive towards obesity, because the truth is that if you were to give us a grade on how we're doing in counseling patients about diet and exercise, the truth is we're failing. We get an F, which most doctors are not used to getting. And so I think we need to stop that conversation about just diet and exercise because I don't think that's getting us anywhere. We need to look more in depth and talk to patients more in depth. But even just that word, diet and exercise, well, what's the best diet? And there's a billion-dollar industry out there telling you what diets are best. Is it paleo? Is it Mediterranean? Low carb? I mean, the books that you can buy are extensive. Personally, I think we've made it way too complicated for patients, that we need to simplify it, that fresh fruit, vegetables, whole grains, lean meats, and portions should be what we talk about, and getting rid of all processed foods. And that, I think, is where we've made it too complicated. A lot of patients will come in and say, you know, why can I not lose weight? I've started to exercise and I'm exercising regularly and nothing's changing. And this slide is going to talk about that. So when you look at exercise and weight loss, first, the American Heart Association talks about 150 minutes of moderate cardiovascular exercise a week. And then now they've added 2 sessions of weights or resistance, 30 minutes. Well, the truth is that's nowhere near enough exercise to lose weight. In fact, just to maintain weight loss after people have lost weight, you need about 300 minutes a week. If we're talking about clinically significant weight loss, in this study, it was only 5%. It's if people did 300 to 450 minutes per week for 3 years. And so for those of us who work, have kids, the idea, I mean, I'm super impressed if anyone can exercise for 450 minutes a week consistently for 3 years. That's incredibly impressive, but not really realistic for the majority of patients. And then people will say, oh, it's the type of exercise they did, but actually that's not true. So if you look down in this study, if someone was doing aerobic exercise, they lost about 2 to 3% of their body weight, and only with very high levels could they obtain clinically significant weight loss. Resistance or weight training, 0 to 1%, and very unlikely. If you add aerobic and resistance training, again, 0 to 3% body weight loss and only at really high levels. If you go to calorie restriction with aerobic exercise, you do get, and again, this is over 3 years, not 3 months, which a lot of patients will come in when they're frustrated after 3 months of working out. But you can get 5 to 15% body weight. So it's definitely possible, but takes a lot, and a lot more than I think most patients can commit to, and for longer periods of time. So breaking down lifestyle changes only. So this is, I will point out that a lot of these studies were short-term, not long-term. We know that people can go on these programs where they, first of the year, they join and they do exercise and diet. And then after a few months, they stop them and then they gain their weight back. But even just in the short term, doing like MyFitnessPal for 12 months, that lost 2.2% body weight on the average. Commercial programs like Weight Watchers, which are huge programs that many people have spent a lot of time in, especially within my weight loss clinic, you can lose 3 to 5% at 12 months. Jenny Craig with meal replacements, yes, the rates are higher, but I will tell you, as soon as patients stop meal replacement programs, they 100%, most of them will gain their weight back. It may not be immediately, but it will be within the first couple of years. And then intensive lifestyle with meal replacement, about 8%. So just to kind of highlight those programs. So what a lot of those things lead to is what we call this yo-yo dieting or weight loss cycling. And I love this little cartoon because this is true, I think, for a lot of us, that before, and then we go on these diet programs and we lose weight, and then we stop those diet programs or there's eating programs. My favorite is low carb and paleo. Almost no one I know can maintain that for very long. And as soon as you go back, you actually end up often gaining more weight than you initially started with. And that process of yo-yo dieting, losing weight, gaining more weight, is actually worse for our health overall. It can increase our percentage body weight within our body. It slows our metabolism down. A good example of this was The Biggest Loser. I don't know if you guys are old enough to remember that show, but they took 16 contestants. They put them in really intensive diet and exercise programs. They lost, I can't remember now the study, but tons of weight, basically 100 pounds or more over that time. Well, unfortunately, all of those patients, except for one, actually gained their weight back pretty quickly. And what they found, someone was smart enough to check some of their biologic metabolism markers before and then after, and then when they gained their weight back. And the truth was that their metabolism dropped significantly. I think this is the biggest issue with maintaining weight loss, is that the amount of energy we expend just living drops significantly. I think it's probably a survival mechanism for us, that when there were times of famine, our body wanted to put on weight, right? It's safer for us to put on weight after we've lost it. And so we really have to struggle against that. And people have asked me, well, gosh, when does that go back? Like, how long does it take after I've lost weight for my metabolism to go to where it was before the weight loss? And I don't think we have a good answer for that yet. But people are really looking into it. But that, I think, is a huge part of weight loss cycling. There's some negative cardiovascular risks. So this person had more risk than this person had. For example, hopefully you guys can see my arrow that I'm pointing at. There's increased mental health risk and actually increased body pain irrespective of weight. And so what we really want to do is avoid yo-yo dieting and weight loss cycling. And that's what a lot of those diet and exercise programs that people can do for a short term end up causing. So the truth is that most people need help, that this is not a personal failure. A lot of this is outside of their control, and it's not, not their fault that they're having a hard time losing weight. And most people need treatment and help. And that's kind of the point of everything I've been trying to say before. So talking about the different treatment options, kind of changing gear, the first thing that I will say is that bariatric surgery, especially for patients that need to lose significant amounts of their body weight, is by far the best option. There are goods and bads about that, and you can definitely talk to your doctor about that. But long-term weight loss surgery definitely is the most successful. So on this graph, this is different weight loss procedures, and you see that patients can get down 40% in weight loss at 3 years, which is amazing. And like I mentioned before, weight loss surgery can decrease mortality and cancer risk by 35%, which is significant for sure. Unfortunately, we do, probably related to that metabolism issue, see some weight gain, but even at 10 years, the weight loss is still very significant. So if patients are not comfortable moving to surgery, or it's just not the right choice for them, the next treatment option is medications. And here is a timeline of the different FDA-approved weight loss medications and over time. There are some good medications that have been around for a while. I'm not going to lie, they have some side effects, maybe more side effects than newer medications. But there are some good medications out there that often are covered easier by insurance. Then you get to the GLPs and these newer generations of GLPs. And these are the ones that everyone probably has heard of if you've watched the news. So Ozempic, in Wegovy, semaglutide, they are all the same medication. The reason that you hear different names is because these medications were first used to treat diabetes. And so we actually have longer time safety profiles on these medications from patients that were using them for diabetes. But that's why the names are different and how they marketed them, but they're all the same medication actually by the same company. Zaybound is Mounjaro and tirzepatide. So those are the newer medications that have been approved and are getting a lot of things about them in the press, good and bad. Some of it deserved, some of it not deserved, I think. I will point out that initially these medications were used to treat diabetes, and those medications for diabetics, there is no timeline on those. They're often continued indefinitely. And so people ask me a lot about the concern of using these medications for weight loss indefinitely. And I tell them that I don't think there's a problem with that, actually, that we have good data for that. The only other medication I added here was metformin. Metformin is an old medication used to treat diabetes, really great medication, actually. Has some side effect issues, which can limit its use, but it's never sought approval by the FDA for weight loss, but most studies show it loses about 5% of weight. So I thought needed to be mentioned there as well. So when we look at, sorry, this is my graph and I'm not super computer savvy, but this is the effectiveness of anti-weight loss medications in terms of percentile. I wanted to kind of make it similar to that graph on surgeries. But if you look at the different medications here, this is the percent weight loss average for studies. I will say that I use a lot of semaglutide, and I get quite a bit in most patients, higher weight loss than just 15%. Tirzepatide is this one here. As you can see, tirzepatide has been shown in the studies to help with a higher percentage of weight loss. The reason for that is a couple, but it's what we call, well, I don't want to get too complicated, but basically it works in two different ways, where semaglutide works in one way. But you can see there's some decent weight loss associated with some of these other medications, older medications as well. But that's why these are so popular right now, because it's the first time that we have great success with medications for weight loss. I could spend a whole hour talking about the GLPs, the Ozempic and the Mounjaro, and what they do and how they work. I just wanted to throw this graph up there really quick, or the slide up here really quickly, to say that you've probably heard some data that they're now approved to decrease cardiovascular events and potentially decrease sleep apnea and help with liver issues. And that's because these medications work in multiple different ways. I think one of the things that maybe isn't given enough attention is how it impacts our brain. And it is an appetite suppressant, and so you're not hungry. But it works a little bit also in our craving centers of our brain. And one of the things my patients talk about the most is how helpful it is for food noise. I don't know if people have heard that term before, but basically it's that constant energy, that constant thinking about food. When am I going to eat? What am I going to eat? All those things. And a lot of patients don't realize they have that until it's gone. But that is really refreshing about these medications and how helpful they can be for that. Okay, just a brief amount about the Women's Health Weight Loss Clinic that we started. First, it is a combination of lifestyle changes, so we absolutely spend a lot of time on that. We also focus on weight loss medications for treatment. We do bill insurance, at least for the visits. A lot of the medications aren't necessarily covered, which is unfortunate, and I hope that will change. The reason for that is complicated, and there's lots of different things out there that talk about why that is. But our clinic specifically, we are using medications to help. Our initial visit, so who's can qualify for our clinic or some of the other weight loss clinics. First, it's based on BMI, so people who have a BMI over 30 or 27 and have weight-related issues. For example, diabetes, high cholesterol. I'll do a lot of endometrial hyperplasia, which is like a precancer for endometrial cancer. hypertension. So any of those other disease processes that we know are related to weight. We take a medical history and a weight history, what's worked for patients, what haven't worked for patients, why do they feel like they've gained weight? Everyone's not the same. We do screening for mental health disorders, binge eating disorders, because we know from a lot of studies that that risk is really high in this particular population. We do referrals. I try to talk all my patients into a nutrition consult referral. Some of them do, some of them don't. And then behavioral health as needed. And then we try to choose the best weight loss medication for patients. And then we set goals. Often we have more than one goal. Some patients' goals are an actual weight, like, hey, I want to weigh 140 pounds. Other patients have different goals. For example, they want to get healthy before they get pregnant, which is a great reason to lose weight. I see that a lot. I want to have less pain related to my knees. It hurts when I walk. Um, Patients have, let's see, other ones decreasing cancer risk. If they've had breast cancer, they want to decrease their risk of a reoccurrence. So patients all have different goals, but we want to talk through those and set those. I personally set up so that all of our follow-up visits are what we call telemedicine visits, because we know that the more a patient sees the doctor, the more likely they are to have success. But it's very difficult for patients to get off work, to come to the doctor frequently. Our clinic is very busy. It's hard to get appointments. And so I do all of mine telemedicine. I want to come to patients so that it's easy for them. And so patients get, like, I call it a HIPAA compliant FaceTime call, essentially, where they can click on and then we meet. Most of those are done at the end of the day. I try to do them a lot after 5 when I know patients are off work, or if we talk about it, they can do it early or whatever. But basically, almost all of our appointments are telemedicine follow-up. Patients are more than welcome to come in and see us, but I know that is really difficult. The second thing is we spend a lot of time adjusting the dose of medication. The dose is different for every patient. If people have set protocols, I don't think they're doing a good job for patients, because everybody's different and everybody needs a different dose and they need to go up at different times. And so we spend a lot of our time adjusting to that. We manage side effects. So a lot of patients come to me and they say they're concerned about getting on these medications because they've heard there's so many side effects. And I tell patients 100% there are side effects. Everyone will have side effects on the medication. But I have very few patients. I probably should look at what the percentage, but very few patients that actually stop the medications due to side effects. Most of the time, we teach patients how to manage those. We give them medications to help with nausea, medications to treat constipation, diarrhea, which are some of the more common ones. And then just teaching people how to eat really slowly, to stop when you're hungry, to eat regularly. Those are really good habits, both on the medications and off the medications, for eating healthy. And so we spend a lot of time going through that. We spend a lot of time going through education, that lifestyle changes that we talked about. For example, I try to talk about mindful eating. When I say there's no eating program that's actually been shown to be successful long-term, that is not true. Mindful eating is the only one that has been shown to be successful. So what is our relationship with food? How do we eat? When do we eat? What do we eat? And really working on mindful eating, which is something especially I think women have a hard time with. A lot of education on portions, like I talked about before. I think that's a huge problem. Um, for example, you can eat salad all day, but if you eat too much, you'll still gain weight. I always joke about cows walk around eating salad all day, and we can see what happens to them. So really educating patient on portions. Giving up alcohol and soda is a huge thing. Not that you can't have any alcohol, but regular alcohol is not good for us. And actually, you don't feel good on the medications with that. And then learning how to be, I call it water addicts. So people who drink water all the time, who always have their water bottle with them. Um, Education on food in general. I was surprised by how much lack of nutrition education there was out there, and people thinking they knew healthy foods and healthy ways to eat, but they were not. And then most of my patients come to the realization that they have to food prep. They have to make their own food. That's the healthy way to eat. Importance of exercise, especially we talked about on the weight loss, to maintain on that slide with exercise and weight loss, to maintain weight, you have to exercise a certain amount. So definitely we stress exercise, good sleep, stress management, setting goals. And so that's what we spend the majority of our time on the weight loss clinic teaching patients, because we're hoping to set them up for success when they're able to hopefully come off the medication, as I don't want them to be on them for life. So that is just a very quick, rush glance into our weight loss clinic. So that is the end of the talk, and I'm gonna hopefully get to some of the questions, but please put your questions in the talk. I'm happy, or in the question box. I'm happy to go through those. Joined by my friends today. You might want to turn off your back. Yeah, thanks.
Okay. First question.
Okay.
Besides weight loss, what are the long-term effects of things like semaglutide and Ozempic on the female body? Any concerns or additional benefits?
Yeah, so great question. Semaglutide is being studied, or the GLPs in general are being studied on, if you look at that slide I had up of all the different areas that impacts it, there's some question about whether it actually is going to decrease rates of Alzheimer's, which is being studied to treat alcoholism. So those things that they're looking at are actually all in the positive. Have we heard negative side effects from the medication? I think the biggest negative side effect that's really coming out is if patients stop these medications, their risk of gaining weight back. And so, but really like long-term negative side effects really shown in studies, I don't think so. And like I mentioned before, we have a lot more historical data in patients using it for diabetes and safety profiles from that. But as far as we know, not really significant.
Are there any new studies with these drugs causing pancreatic cancer?
Great question. There is an increased rate of pancreatitis in these medications. The majority of those were thought to be related to people losing weight too quickly, getting too dehydrated. A lot of different opportunities online to use these medications without close follow-up from physicians, which I think are really dangerous. I think you can find a study that says anything, actually. It's when these studies are shown over and over again with larger populations that I think they become concerning. But no, I don't caution patients about that.
In your initial consultation, do you consider underlying medical issues before suggesting weight loss medication?
Yeah, so I think that's part of choosing the right medication for patients. The same medication is not the best for everyone. Fortunately, there's not a lot of contraindications to these medications, only a certain kind of thyroid cancer or very rare endocrine disorder within families. So most of the time, the GLPs are safe for people to use.
Do you need a physician referral to come to the clinic?
You don't actually. So you can call Women's Health and they can get you scheduled for what we call a weight loss intake, where we kind of go through all this information. If we don't have room for patients, we're trying to help send them to other clinics that have weight loss programs. In fact, I just got a contact from a provider in Meeker who's going to start a weight loss clinic and kind of getting some ideas from our clinic. And so there are other places other than just us at Valley View. Internal medicine, some of the family practice doctors are doing it that can also help patients.
What other options are there in regards to medication when pregnant and postpartum? I'm curious about losing weight after pregnancy. My family has a history of obesity.
Great question. Right now, in fact, very strongly, we do not recommend these medications when women are pregnant or breastfeeding or planning to get pregnant soon. In fact, I make all my patients be on birth control if they're taking these medications, because we would never want to risk harming a fetus. So that's a little bit more limited. And in general, we don't want people losing weight when they're pregnant. Healthy lifestyle, absolutely, but weight loss, not necessarily. Postpartum, some of the older medications are safe to use breastfeeding, but not the newer ones.
What are the options for men in weight loss clinics?
Okay, great. So same kind of answer to before. Some of the internal medicine doctors, family practice doctors around the area are doing that too. So talk to your primary, I think, is the best place to go first, or our internal medicine clinic at Valley View specifically is running different studies on weight loss with the University of Colorado, so the partnership there.
What are your thoughts on changing the standards for BMI and if it's useful? Should we use it as a standard in healthcare?
Great question. Like everything, there are goods and bads to everything. I think it's the most universally used thing now. And um, that's come up in my clinic actually about measuring people's percentage of body fat and whether we should be doing that. I think that's a little bit intrusive. I don't think people really want me like squeezing them and going around their waist and stuff. But obviously BMI is not perfect. They always use The Rock as the example. The Rock technically would be obese, but we all know he's in great shape. Okay, most of us don't look like The Rock. And so I hate when we use examples of rarities and when majority of population, I think BMI is probably very accurate.
Okay. Do any of these medications work better if you are in menopause?
I don't think they work better. In fact, I think it's harder to lose weight after we go through menopause, going back to that physiologic thing that we don't quite understand about how metabolism changes.
Is the only option medication?
So, with the weight loss, the number one being bariatric surgery or weight loss surgery is probably the most successful. And I will refer patients there and tell patients that that is the most successful for them, especially if they need pretty significant amounts of weight loss. There's a lot that goes into that surgery. I think it actually takes a lot of bravery to go through those surgeries, and they're just not for everyone. Um, there are other medications other than the GLPs. There are intense exercise and diet programs that show some success. I think majority of people do not have success, is the truth. But I don't think that they're bad. In fact, I think they're really great. And that's what we do spend our time on. It's just that most people need medicine as a tool. It's not the answer, but it's a tool to help them be successful.
Can you share a list of the providers who can support men, or do you just start with primary care?
So specifically, I refer patients down to internal medicine to Lindsay Bennett, who's doing that program. But I know there's some providers in, I think in Grand River doing some. So this is such a huge health issue. I think wherever patients can get help, I want them to get help. But if those don't work for them, then I think talking with a primary is a great place to start.
Can these medications be used with hypothyroidism?
Yes, absolutely. In fact, they're very helpful with thyroid. So I think that was that rare tumor and thyroid somehow in the public got that anyone with thyroid disease cannot use these medications, and that is not true at all.
How about patients that do not want to take medication for weight loss? Suggestions for those that don't have a significant amount of weight to lose.
Okay, great. So hopefully some of the information I gave you is helpful and true. I'm happy, and all primary doctors would be, pediatricians would be happy to talk about lifestyle changes that patients can do. You can get a nutrition consult, which I think is really helpful. A lot of the different gym programs here have um, uh, coaches, weight loss coaches that are helpful. I think all of those things have a lot of value. I just want patients not to get down if they've tried those things and they haven't worked, that there's, it's multifactorial.
Could you expand on losing the weight too quickly related to the pancreas?
Um, oh, um, I, I think not going too deep into the biologic parts of it. I think there's a lot of harm in losing weight too quickly for a lot of different reasons within our body. And so the healthy way to lose weight is a slow and steady weight loss over time, small changes that we can maintain. Anyone can go on a paleo diet and lose a lot of weight very quickly. The problem is that those never work long term. And what we want is patients to have success lifelong, not short term. And so really slow, steady weight loss is really important.
Do the weight loss drugs you mentioned earlier improve energy levels, or is that effective?
Um, Good question. I think that, oh, let me not log us out. I have a lot of patients who have a significant improvement in their energy, feel really good, whether that's they're finally seeing success for weight loss. There is some improvement in decreasing inflammation. within our body, whether that's related to that, the medications. I think when patients start to see success, it helps motivate them. They're more likely to go to the gym when they're actively losing weight. We know exercise improves energy levels. I have a few patients who notice some fatigue on the medications, but that's really quite a minority of them.
How often do you refer to a registered dietitian?
Yeah, I try to get everyone to do a nutrition consult. I think there's a lot of value in that, not only just at the beginning of the program, but especially after they've lost weight to help them maintain that weight loss. A lot of patients have had a lot of education through their life. They've been on Weight Watchers. They've tried different things. They feel like they are educated. And so not everyone takes that, but I try to get everyone to do it.
That is all the time we have for questions.
Okay, it's great. Thank you guys again for all your questions and for joining us. We would really like to have your feedback on the presentations. So if you have time, fill out the quick survey that's going to come right after the webinar has ended. You will get an email if you register for the course that has the recording of this webinar, which I encourage you to forward to any of your friends or family who might be interested. The next webinar for the Women's Health Series is actually next Thursday at 12. It's Dr. Jamie Lowe who's dealing and discussing bladder issues and treatment, which is really common in women, especially as we age and especially as we have children. So great talk. Okay, thank you everyone again.